we are moving on to the topic, the ulnar nerve. So, we are going to discuss this topic under the same thing, okay, how its formation, course with branches, with applied aspect. Okay, so now the formation of the ulnar nerve. The ulnar nerve, we know it is formed by the posterior cord of, medial cord of the brachial plexus. So its contribution is CA-T1. So ulnar nerve, which is a branch from the medial cord of brachial plexus, is its root value is CA-T1 and it receives contribution from the C7 also. So the ulnar nerve is formed, the root value of the ulnar nerve, you can write it as C7, C8 and the T1, and after it runs in the axilla. Once it formed, it runs medial to the axillary artery. So in the axilla, it runs medial to the axillary artery. So it runs medial side of the brachial artery in the arm. Okay, once it crosses the mid, it reaches the mid of the arm at the level of insertion of coracobrachialis. It pierces the medial intermuscular septum, right? It pierces the medial intermuscular septum. It pierces the medial intermuscular septum and it becomes posterior. Okay, it pierces the medial intermuscular septum along with an artery called as superior ulnar collateral artery. We have already discussed this artery during our anastomosis around the elbow joint. Okay, anastomosis around the elbow joint. So this ulnar nerve at the middle of the arm, it pierces the medial intramuscular septum along with the superior ulnar collateral artery and it goes back, right? It goes back. Then it reaches the it reaches behind the medial epicondyle. So this reaches behind the medial epicondyle of the humerus. Here it will be behind, it is converted into the cubital tunnel. Okay, so the cubital tunnel is nothing but the fibrous tunnel is the fibrous band extending between the medial epicondyle and the olecranon process. So the nerve can be compressed under this cubital tunnel and leads to the cubital tunnel syndrome. So the cubital tunnel is nothing but the ulnar nerve is compressed between the fibrous band extending between the olecranon process and the medial epicondyle of the humerus. So once it reaches, so it is passing behind the medial epicondyle. So this posterior course is shown in the dotted line. Now it enters the forearm by passing between the two heads of, okay, it passing between the two heads of the flexor carpi ulnaris. Flexor carpi ulnaris. Okay, so now it reaches the anterior part of the forearm. So till now it has not given any branches in the axilla or the arm. In the forearm, we already discussed it is giving branches to the two muscles, that is flexor carpi ulnaris and the medial two heads of flexor digitorum profundus. Okay, so after giving the branches, then it descends in the forearm. The ulnar nerve is the most structure in the forearm. It lies medial to the ulnar artery and just lateral to the flexor carpi ulnaris in the lower part of the forearm. I repeat, in the lower part of the forearm, ulnar nerve lies medial to the ulnar artery and lateral to the flexor carpi ulnaris tendon. Okay, so after that what happens? Just at the mid forearm, it gives a branch that is called as dorsal cutaneous branch, right? It gives a branch that is called as dorsal cutaneous branch that supplies dorsal cutaneous branch. Okay, so while ulnar nerve is descending, it gives a dorsal cutaneous branch that goes backwards dorsally and supplies the skin over the medial 1.5 fingers. Okay, so here it supplies the medial skin over the skin over the medial 1.5 fingers. 1.5 fingers in the dorsal aspect. Okay, so after that the ulnar nerve descends in the forearm. Okay, so here consider here will be the flexor retinaculum. Before entering into the flexor retinaculum, it gives a palmar cutaneous branch. It gives the palmar cutaneous branch. So palmar cutaneous branch, we already know that it is supplying the skin over the medial aspect, okay, palmar on the over the hypothenar muscles. Okay, this palmar cutaneous branch is one which supplies the skin over the hypothenar muscles, and the dorsal cutaneous branch supplies the skin over the dorsal aspect and also to the fingers, or skin over the fingers for the medial 1.5 fingers. Okay, so after that this ulnar nerve enters the superficial to the flexor retinaculum in the Guyon's canal. We have already discussed this here. There will be a superficial slip, that is the ulnar carpal ligament, no, that is given, and this enters via, anyway it passes superficial to the flexor retinaculum, and its distribution will be, now I will show its distribution. Okay, so for that, this is the thumb. Okay, so once it enters, it divides into superficial branch and the deep branch. Okay, this superficial branch supplies the palmaris brevis. Okay, the superficial branch supplies the palmaris brevis, and this one, and there also it continues as the one proper digital branch and one common digital branch that supplies the medial 1.5 fingers. So this is about the superficial branch. Okay, so the ulnar nerve enters superficial to the flexor retinaculum, and once it enters, it divides into the superficial branch and the deep branch. The superficial branch supplies the palmaris brevis, and also it divides into digital branch, one common digital branch that supplies the either side of the fingers, and one proper digital branch that supplies the medial side of the little finger. Once it gets over the deep branch, okay, so the deep branch supplies, okay, the deep branch, now this is the deep branch that supplies the hypothenar muscles. Okay, so hypothenar muscles it supplies, all the three hypothenar muscles it supplies third and the fourth lumbricals. Okay, it supplies the third and fourth lumbricals, it supplies the third and fourth lumbricals, it supplies the palmar intraossei 4 and the dorsal intraossei 4, and ends by supplying here, I already told you here what is the muscle, adductor pollicis. So ends by supplying the adductor pollicis. So the curve of the nerve, okay, deep branch of the ulnar nerve is from the medial to lateral side. While it passing from medial to lateral side, the deep branch supplies the hypothenar muscles, third and fourth lumbrical muscles, all the palmar intraossei, all four dorsal intraossei, and the deep branch ends by supplying the adductor pollicis muscle. So mostly of the intrinsic muscles of the hand is supplied by the ulnar nerve. Hence I will repeat the ulnar nerve. Ulnar nerve is formed by the C7, C8 and the T1 root. It runs medial to the axillary artery, and again it continues to the medial side of the brachial artery. At the mid of the arm, it pierces the medial intramuscular septum along with the superior collateral artery, and it descends posterior in the posterior aspect of the arm, and it is related to the posterior aspect of the medial epicondyle, where it can be compressed under the cubital tunnel, which is a fibrous band that is extending between the medial epicondyle and the olecranon process. After that, it enters the front of the forearm by passing between the two heads of the flexor carpi ulnaris. After that, while passing only, it supplies the flexor carpi ulnaris. Okay, after that also it supplies flexor carpi ulnaris, and also it supplies the medial two heads of the flexor digitorum profundus. After that, in the mid of the forearm, it gives the dorsal cutaneous branch that goes dorsally and supplies the skin over the medial 1.5 fingers. Okay, then it continues, ulnar nerve continues. Then it gives the palmar cutaneous branch that supplies the skin over the palmar aspect of the over the hypothenar muscles, okay, over the hypothenar muscles. And once it passes, the ulnar nerve passes superficial to the flexor retinaculum, it divides into the superficial branch and deep branch. Superficial branch supplies the palmaris brevis and the to the 1.5 medial 1.5 fingers, and the deep branch supplies the most of the muscles of the palm, that includes the hypothenar muscles, third and fourth lumbricals, 4 palmar and 4 dorsal interossei, and ends by supplying the adductor pollicis. And the point to be noted is, if the deep head of flexor pollicis brevis, which is a muscle of the thumb, if it is not supplied by the median nerve, it will be additionally, it will receive blood supply, nerve supply from the ulnar nerve. Now we will move to the applied aspects of the nerve. Okay, so if the ulnar nerve gets injured at the level of so mostly the ulnar nerve will get injured, the resulting position of the hand will be, okay, so there will be claw hand, mainly that results in the claw hand. Okay, ulnar nerve injury that results in the claw hand, mostly it get affected in the wrist joint. Okay, it results in the claw hand, which is that is due to the paralysis of the lumbricals. Okay, so lumbricals, usually we has discussed the lumbricals action is Z pattern, which causes flexion of the metacarpophalangeal joint and the extension of the interphalangeal joint. So due to the paralysis, the third and the fourth lumbrical will not be working, that results in the ulnar claw hand, so that there will be flexion at the interphalangeal joints and the extension at the metacarpophalangeal. So ulta action, because of the paralysis, ulta action will be there, and there will be the forearm will be in the pronated position, because there will be the weak flexion of the wrist. Okay, as usual, there will be the weak flexion of the wrist, and there will be in the abducted position. Why the wrist will be in the abducted position? Because here the nerve supply to the flexor carpi ulnaris is lost, which is responsible for the adduction of the wrist. So flexor carpi radialis, which will take over the function, that results in the abduction, the abducted position of the wrist. Then there will be sensory loss over the distribution of the ulnar nerve. Sensory loss. And finally, there will be we can test by the 4 months sign. 4 months sign. What is mean by 4 months sign? Okay, when we hold since the adductor pollicis, which is responsible for the adduction of the thumb, if we place a paper between the thumb and the index finger, the person has to hold the paper by means of adducting the thumb. Okay, so if the ulnar nerve is injured, what happens? The person will try to hold the finger by flexing, not by adducting, because the flexion of the thumb is maintained by the median nerve, by the flexor pollicis brevis. So when he want to try to hold the paper in place, he may try to hold the paper by flexing, not by adducting, because the adductor muscle, which is supplied by the ulnar nerve, is weakened, or it is paralyzed. So this is the 4 months sign, that is also called as paper cord test. Okay, so here the person tries to hold the paper between the thumb and the index finger by flexing, not by adducting, because the adductor pollicis, which is supplied by the deep branch of ulnar nerve, is paralyzed. Okay, and you should know a point about ulnar paradox. Ulnar paradox is nothing but it is a more distal the nerve injury, more distal the injury, and the clinical sign will be worse. Okay, usually more proximal the injury, the clinical sign will be worse, but here the distal the injury, the clinical sign will be worse. So that is the distal injury, but more clinical defect. That is the ulnar paradox.